Good morning.
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 Good morning. Good morning. Hi there.
Yay, I made it.
Finally.
Finally, I made it.
I know. I made it today, and I was like, oh my God. How early did you guys log on to make it?
7 a.m. I was
9
I've been trying for a half hour.
9 o'clock.
It's 10 o'clock.
9 o'clock.
Waiting
Since what, 5 o'clock in the morning?
Nay, I've been on here for like the last hour.
It
It
was
says she's in another meeting.
Yes.
Oh my goodness. I'm so
Yeah.
happy you guys made it.
Yes,
That's
thank
awesome.
you. Thank you.
Okay, we're going to begin shortly. Wow, the room's already full.
Hi, Professor B.
Good morning.
Good morning. I'm all the way from the Caribbean, St. Vincent.
Hey,
Oh,
Vincent, all right.
I'm actually at work.
Do not get fired.
No, I won't.
Okay, we're going to begin shortly. I'm going to mute the chat just so it can be nice and quiet and you guys can hear me. And then at the end, I'll answer questions. And then I'll post it onto my YouTube channel. So if you guys want to go over anything that I've covered, the demand for this has been incredible. And because of COVID, I'm just not doing live reviews like I used to. I'm home with the kids and things I do on social media, but I know the need is there. So I'm going to try my best to do a live Zoom session for you guys at least once a month. I can't make any promises, but that's what I'm going to try to do. Now, this resource that I'm using, I still haven't found out who's the original maker of that resource. So I can't share it with you guys because I'm not trying to have anybody come back and sue me. I really don't know. I'm still looking, but you guys can still go onto the YouTube channel and just press pause if you want to take notes or just go over that material, because I'm going to be covering this before I move on to something else. Okay. So I'm going to mute everyone, then I'll share my screen so we can begin. Oh, you guys are so kind. I see everything on the chat box. Vel, you're so funny. Okay. I'm trying to mute everyone. Here. Let me see if this works. Okay, I'll reopen up that chat box, guys. Once the lecture is complete. Well, not lecture, I'm just going to be teaching you guys. I don't like calling it lecture, but once that's complete, I'll open up the chat so I can answer questions. Guys, please put yourselves on mute because for some reason I can't figure out how to mute you all, and I don't want to have to keep stopping and asking you to mute yourself. So anyone, if I'm hearing noise from you, I'm going to have to kick you out of the room. So I'm asking you now, just put yourself on mute so I don't have to kick you out. Okay?
Mute.
Put yourself on mute, please. Can you guys see my screen?
no. Yes.
Dr. D, please enable us to record.
Professor's recording the lecture. She
This
says
is
she
being
will post it on
recorded, guys.
YouTube.
It's being recorded. Bash Girl 1, please put yourself on mute. I'm about to begin. Andrea, Alexis, put yourself on mute, please. Okay. Now, slides 1 and 2, I'm not going over them because that's already, I went over that on my first Zoom and that's already posted on my YouTube channel if you want to see that. So I'm going to start with this prioritization techniques. As students, let me make it just a little bit bigger for you. You guys tend to have a problem with this, figuring out who's your priority patient? Who do you see first? So here are some tips and I'm going to add some things to it. So you're always going to prioritize systemic versus local. So if you have a patient that something's wrong with their left arm, but you got another patient that's having systemic symptoms, they're having fever, they're having chills, the symptoms are generalized, it's all over the body, you're going to go to the one who's having symptoms all over the body versus the one who has something localized, just one part of their body. And the reason for that, guys, whenever you're getting questioned about who your priority is, what they're really asking you is who's going to die first. You're going to run to whoever's at risk of dying first. So think about it. You got patients, something's wrong with their left pinky, and you got a patient, something's wrong with the blood, and the blood goes everywhere, right? Who's more likely to die? The patient with something wrong with their blood. So that's who you're going to run to first. So that's what I mean when it says systemic versus local, okay? Life before limb. You're going to prioritize acute versus chronic. If something's acute, that means it's happening to the patient right now. If something's chronic, they've been dealing with this for a while. And the reason that we're going to prioritize acute over chronic, your body's meant to survive no matter what. So if you have a condition that's chronic, you've been dealing with it for a long time, your body starts to adjust. It doesn't mean you're fine. It just means that your body is adjusting, trying to keep you alive. So for example, patients with COPD, right? Their body starts to adjust to having low levels of oxygen versus someone who's having an acute episode of asthma where they can't breathe. Who are you going to run to, that patient with COPD or that patient with asthma that's having an acute episode? You're going to run to that patient with asthma that's having an acute episode because they're the one who's at risk of dying the quickest, okay? You're going to prioritize, I'm right here, guys, on the third one. You're going to prioritize actual before potential future problems. Always. We always care about what's happening to our patient now versus what may possibly happen, okay? Next, prioritize, and I talk about this a lot.
Hello. I'm sorry.
Sorry to interrupt, but you're not sharing the screen.
You can't see my screen?
No.
Yeah, I can't see it
Let me go
either.
back. Thank you. I thought I was sharing. You guys still not seeing my screen, are you?
No.
Oh.
No.
No.
Okay, hold on. I don't know why it's doing this. I might have to switch laptops with you guys. Give me a sec.
I can't hear or see anything.
She's coming. She's trying to fix it.
See, I go to share screen. It's not showing the actual screen. It says allow Zoom to share your screen, but when I do that, they still can't see my screen. Go back over here.
Can't see your screen.
No, because when I share, I should be able to see it as well. You guys still can't see my screen, right?
No,
No.
No,
No.
we can see you, but we can't see your computer.
I think you have to select your screen that you want to share.
I did, but I wish you guys can see. I selected the screen I want to share, but it's still not showing anything. Give me a sec, guys.
Just go to your system,
Go to what?
go to the setting, go open system preference, security, privacy to grant
All right,
access.
there's settings. Hold on. Try to- Get rid of this. Okay.
Go to Zoom.
I double click on it. Guys, I'm sorry, give me a second. I got a new MacBook and some kind of security setting. So my husband's trying to allow Zoom.
We're praying, believe me.
Go back to settings right here.
Find that app, Zoom, the Zoom app.
Like this right here.
I should be able to go to setup, find a Zoom app, give it permissions to share screen.
Here, I'm in a Zoom account. Can I do that through the account?
No, you can't do it through the account. You have to
No.
do it through. It's not familiar with Mac, so. What all your apps?
They're all down here. Like here, like Safari, Chrome, they're all down here.
See how you have the Apple Store on your
Uh-huh, uh-huh.
Where's the Apple? Where's the all the apps?
Like here.
Pull up Zoom, go into it, and just you have to find it and click to allow it.
All right, I don't want to waste time, but I wonder, since this is being recorded, if it's too late, if I can just switch to this laptop, which is already configured with Zoom, or it'll be too late.
No, you should be able to log into it.
'Cause let me tell you something. If these students can't get back in, they're gonna lose their minds. Some of them been on since like 6 a.m. trying to get in.
Lord, please. Don't touch nothing.
Okay. We can listen to your voice.
If the host leaves and come back in another computer, you'll be able to come back in another computer.
Are you sure?
As the host, yes, we can stay here, but the host can leave and come back.
Okay, because I missed the first Zoom. I don't want to miss
Me
this one.
too,
Me
please.
neither.
Yeah,
me too.
Same.
Come back
My
in.
life depends on this, Professor D. Please.
Yes.
Life does not
Can't lose
depend
it.
on me.
I would rather have you teach without the
Yes, without the content.
Yes.
Yes, me too.
Please, please. We can
Maybe you
take
can-
notes.
Yeah, we can
Put them in
take
the
We
notes.
can take notes, please.
Can you share your slides in the
In the
chat
chat.
box?
Yeah, maybe you can link them into the chat.
Yes. Let's take notes on what she's teaching, please.
Okay.
What are apps here? This section.
Yeah, honey, I don't know. You know, I just got this laptop. I have no idea. What I'm gonna do, I'm just gonna start teaching, and I'll figure it out later after the Zoom session. I'll like have Shorty take a look at it.
Yeah, you'll be able to fix that quickly.
Okay. Thank you, honey. All right, let me see with you guys.
Yes, Professor D. This is when we need the kids to help. I'll be like, where y'all at? Come here.
That is so true. Google Drive. This is something.
Professor, we don't need it. We get help by listening to you.
Yes.
Yes, we
All
do.
right,
We
I'm gonna
can go
keep
without
going.
it.
I'm so
Yes.
sorry, guys.
That's fine.
Okay.
Thank you.
Okay.
Professor, can you put the slides in the chat?
That's
Or-
what I was trying to do, but as you know, I'm not technologically inclined. I use Dropbox, Google Drive, Microsoft.
Or you might can log in from your other computer, but don't log off this one yet. See if you can log in from the other one, like at the same time.
You'll definitely be able to do that. And then once you are in on the other one, you can come off of that, the one that's not working, because then you'll have feedback. So once you log in on the other laptop and you see you're in the classroom, then you can come out.
It says this meetings reach the maximum number of participants.
Oh, wow.
You can't get into your own nose.
I can't get into my own.
So don't touch
But,
nothing.
Let's
Fine.
just take notes,
Yeah.
guys. Let's take notes.
Take notes, and I'm sorry, guys.
Already here with my paper and pens.
And
Already
like I
here?
said, guys, this is recorded, so you can watch again and just press pause, okay? Anyway,
Yes,
so
thank you.
the next one says you want to prioritize according to Maslow's. And guys, I talk to you about Maslow's all the time, Maslow's hierarchy of needs. Whenever you have a test question, 98% of the time, your test question, really, they're asking you about one of three things. They're either asking you about ABC, airway, breathing, circulation. They're either asking you about ADPI, assessment, diagnosis, planning, intervention, evaluation, or they're asking you about Maslow's hierarchy of needs. What is most important, which is going to be physiological integrity. Remember, physiological integrity, that's what's on the bottom of the whole pyramid, right? The foundation of the whole pyramid, that's the strongest, that's what's on the bottom, that's what keeps everything together. So what falls under physiological integrity? Glucose, nutrition, fluid and electrolytes, circulation, hemodynamic status, airway, vital signs, blood pressure, respirations, anything that is physically keeping that patient breathing and alive is always going to be your priority. That's what falls under physiological integrity. That is what's keeping that patient alive. So that is always going to be a priority over, remember Maslow's hierarchy of needs, think about what's at the top of the pyramid, psychosocial. If you're choosing between a patient's feelings and their breathing, you're going to choose the breathing. What's keeping them alive is always going to come before their feelings, and it's always going to come before teaching. Okay, that's a priority. Next, how to tackle who do you see first questions. So here's how you do this, guys. When you are given a list of different patients and you're trying to figure out who do I see first, what you do is you look at that list and you say to yourself, okay, who's the most stable patient out of this whole list? Who is the least likely to die? And whoever that is, cross them out, get rid of them. You got 3 left. Between those 3 left, ask yourself the same question. Who is the most stable? Get rid of that person. Now you're down to 2. And usually that's how it is, guys. You usually come down to 2 because both of them are critical. You're trying to figure out which one is more critical. This is where you get to Maslow's hierarchy of needs. Because what the test takers tend to do, guys, they'll give you a patient that has a safety issue, that's an issue for falls. And then they'll give you a patient that's critical, like, you know, their blood pressure's out of whack, or maybe they have hypoglycemia. So when you're down to those 2, it's a safety, and a Maslow's a physiological integrity. Which one's more important? The physiological integrity. Because guess what? Physiological integrity comes before safety. Do we really care about a patient's safety if they're not alive and breathing? That's just what it is. So when it comes down to those 2, always say to yourself, which one falls under physiological integrity, which means keeping that patient alive and breathing. That's the answer that you're going to choose. All right, next, guys, we're going to talk about different transmission-based precautions. And the first one we're going to talk about is airborne precautions. What type of patients go on airborne precautions? So when it comes to airborne precautions, I want you to think of MTV. MTV. M is for measles, T is for tuberculosis, and V is for varicella. Remember, guys, varicella includes both the chicken pox and the herpes zoster, which is shingles. Remember, it's that same virus. When you're a child, you get chicken pox, right? It's a virus. It remains dormant in your body. And then as you get older, maybe something happened, you're immunocompromised, something triggers it. And all of a sudden it goes out of its dormant state and it reappears, as shingles. And you'll see that, can you guys see me? Because I can't see myself.
Yes, yes.
Okay.
Yes.
Professor D, can you slow down just a little bit?
Sorry, I get excited. I'm sorry.
It's no problem, just like a little bit, okay?
So with shingles, you'll see vesicles, but they'll be linear, like in the line. But that varicella the varicella virus, when you think of varicella, is chickenpox and shingles. Chickenpox we see with the younger kids, not so much anymore because we have vaccines, but when it remanifests itself in later in years, we see it as the herpes zoster. That's what we see as the shingles, okay? So when you're thinking of airborne, I want you to think of MTV. M for measles, T for tuberculosis, and V for varicella, which includes the chickenpox and shingles, okay? Now, for these type of patients, guys, that are on airborne precautions, they're going to be in a negative pressure room. You, the nurse, when you're going into that room, you have to wear an N95. That mask has to be fitted to your face. If for whatever reason, the patient has to come out of the room, they're going to wear a regular mask. Like if they have to go for a diagnostic test, whatever it is, they're going to wear a regular mask going to, you know, their test or whatever. But if you're the one going into their room, you have to wear an N95. And again, the patient's going to be in a negative pressure room. Now, something else I want to say to you. What else did I want to say to you about this? Oh, when it comes to chickenpox, if you get a question on NCLEX about chickenpox, what they like to ask is, they give you a situation about a mom that's concerned her kid has chickenpox, but the kid's got to go back to school and she wants to know when the kid can go back to school. And so you're going to teach mom that that child is no longer contagious once those wounds have scabbed over. Once they scabbed over, they're no longer contagious. That's something important to teach the parents. Okay, so now moving from airborne to contact precautions. And by the way, guys, it doesn't matter what type of precautions the patient's on. If we're talking about infection, you're always going to put a patient in a room by themselves, unless you have another patient that has the same type of infection. Sorry for the noise, guys. I live by the airport, and so you'll hear, I live by the airport and a highway, so you might hear sounds. So you never put an infectious patient in a room with someone else unless they have the same type of infection. Very important. All right, so we've gone from airborne precautions, which is MTV, to contact precautions. With contact precautions, I want you to think of Mrs. Wee. Contact Mrs. Wee. When I say Mrs., I mean MRS, that's Mrs. And then Wee, W-E-E. And I'm going to tell you what that stands for. MRS, W-E-E, Mrs. Wee. M stands for MRSA. MRSA, multi-drug resistant. What does the S stand for? Multi-drug resistant organism. Okay, that's your MRSA. R stands for respiratory infections. S stands for skin infections. W stands for wound infections. E stands for enteric infections. An example of that, guys, is like a patient that has C. diff. Remember that word enteric. Whenever it's enteric, it has to do with the GI tract. When something is parental, you bypass the GI tract. When something's enteral, the GI tract is included. So that E stands for enteric infection, such as C. diff. And the other E stands for eye infection. An example of that would be conjunctivitis. So patients who are on contact precautions, you're going to think of Mrs. Wee, MRSWEE, which is MRSA, respiratory infections, skin infections, wound infections, enteric infections, such as C. diff, eye infections, such as conjunctivitis. And there's one more thing you need to think of when it comes to contact precautions, and that's hepatitis A. Now, let me scroll down. We're moving on to droplet precautions. For droplet precautions, I want you to think of Spider-Man, S-P-I-D-E-R-M-A-N, Spider-Man. S is for sepsis. It's also for scarlet fever and also for streptococcal pharyngitis. That's your S, sepsis, scarlet fever, and streptococcal pharyngitis. Your P, P's for paravirus. Your P is also for pneumonia and also for pertussis. Your I is for influenza. And guys, that's influenza A or B, the flu, influenza. D, your D is for diphtheria. E, put yourself on mute, please. E is for epiglottitis. R is for rubella. R is also for RSV. You guys remember RSV? Remember you learned in peds? Respiratory syncytial virus. Your M is for mumps, meningitis, and mycoplasma. And last is your A for adenovirus, and that's your Spider-Man. I'm going to repeat it one more time. Sepsis, scarlet fever, streptococcal pharyngitis, paravirus, pneumonia, pertussis, influenza, diphtheria, epiglottitis, rubella, RSV, mumps, meningococcal infections, that's your meningitis, mycoplasma, and adenovirus. All of these patients, guys, must be in a room by themselves unless you have another patient with that same type of infection.
Excuse me, after the mycoplasma, what did you say? After mycoplasma, you said?
Adenovirus, ADENOVIRUS, adenovirus. Now, guys, before I move on, there's something I got to tell you about meningitis because NCLEX likes to ask about this a lot. Let me tell you something. If you, and here's a situation they'll give you. They'll tell you that you're a nurse working in the ER, you're triaging patients, and they'll give you a situation where you have an older adolescent or younger adult, right? Either older adolescent or young adult. They come in with fever, headache, photosensitivity, nuchal rigidity. Oh my gosh, the minute you see that, guys, immediately your brain needs to be thinking meningitis, okay? Those are the classic symptoms of meningitis. Let me tell you something. The minute you suspect a patient has meningitis, you put that patient in isolation, you have them in a room by themselves before anything. Why? You have to protect them from everyone else, right? After we put that patient away in isolation, then we can worry about, you know, doing cultures, drawing cultures, giving them antibiotics and everything else. But the first thing you're going to do, because they're going to ask you what's the order of your steps. The first thing you're going to do, you're going to put that patient on Droplet Precautions. Why? Well, we don't know if they have meningitis yet, but you don't have to know. That's how dangerous meningitis is. That's how it can kill and spread. So very quickly, you suspect it, you're going to put the patient on Droplet Precautions, you're going to put them in isolation, then you're going to draw cultures and give them antibiotics. We are not going to wait for the culture results to come in because remember, cultures take a couple days to grow. So you think while we're waiting for the culture results, we're just going to let that patient die? No, we're going to give that patient broad spectrum antibiotics. We're going to give them antibiotics that kills everything. It kills gram-negative, it kills gram-positive, it kills everything, right? We're going to give them broad spectrum antibiotics. And then once the culture comes in and the infectious disease doctor is looking at the results and they say, okay, this is the type of infection the patient has. This is what's going to kill this bacteria. Then the doctor is going to change the type of antibiotics the patient has. But we're not going to wait for the culture results because time is of the essence. So again, if you suspect meningitis, which means you better know those signs and symptoms of meningitis, remember, usually it happens in older teenagers, like 17, 18, 19, you know, when they go off to college and they're living in the dorms, or they go off to the army and they're living in barracks. It happens to people who are living in close settings, or someone who's in a prison hospital, right? Prison hospital. Someone who's in the prison when they're living in very close quarters with lots of other people. Okay, living in close quarters with lots of other people. Young adult, older teenager, headache, fever, photosensitivity, and most importantly, nuchal rigidity. It hurts for them to flex, to hyperextend, to turn their head anyway, for that neck to move. It hurts. You better suspect meningitis. You're going to put the patient isolation, get cultures, and give them antibiotics right away. Okay? Moving on.
Good.
Put yourself on mute, please. This sounds very simple, guys. And I think sometimes you test, you think to yourself, this is way too easy. And you don't choose that as your answer, guys. I don't want to kick anyone out of here. Please put yourself on mute. Check your computers, make sure you're on mute. The number one way to prevent the transmission of infections has been and always will be hand washing. Always. Not giving antibiotics, not close assessment. Prevention of the transmission of infection is always going to be hand washing. And guys, that's an easy question to get right. Guys, please put yourself on mute. All right, now let's talk about positioning, guys. I'm going to start with postural drainage. So a patient is getting fluid drained from their lungs. The pulmonologist, the surgeon, is always going to try to go as high as possible to drain fluid from their lungs. Why? Because they want gravity to help. Okay, so you're going to have that patient sitting up as much as possible to help, for gravity to help drain that fluid. Let's say the patient is getting a lumbar puncture. How are you going to teach that patient to position themselves? You're going to tell them to curl their back. You're going to tell them to go like this, put themselves in a fetal position so that the doctor can have enough room to grab that cerebral spinal fluid. So you're going to have that patient curve their back like a C, go in the fetal position. Let's say the patient just had a lumbar puncture. How are you going to position the patient? Flat on their back. Think about it. The doctor just put a needle into their spinal column, right? Do we want that patient to have cerebral spinal fluid leak? No, we want to put pressure on the site. So you're going to have them lie down flat so they can put pressure on the site where the doctor just inserted that needle. Very important, okay? You're going to do neural checks for the patient. Let's say your patient just had cataract surgery. Remember cataracts, guys? That's the clouding or the occlusion of the lens. They just had surgery for that cataract to be removed. How are you going to position the patient? You're going to position them on the unaffected side. So if they had cataract on their left side, they have to lie down on their right side. We don't want to put pressure on the area where they just had surgery. We don't want to do anything to disturb that surgical site. It's not like where the patient had a lumbar puncture and we want to put pressure on the lumbar puncture. No, patient had surgery in the eye. We don't want to mess with that surgical incision at all. We're going to have the patient lie down on the opposite side that they had the surgery, okay?
Question, what if the patient had surgery in both eyes? You put them on the back?
What's that?
What if the patient had a surgery done on both eyes? We put them on the back, or?
Yes, they'd lie on their back in a neutral position.
Okay,
which means their body's going to be completely aligned. Next, spina bifida. I'm going into peds a little bit. So guys, spina bifida, that's where the patient, you know how your spinal column is supposed to be closed, the skin's supposed to be intact, but the patient has an outpouching, okay, on the spinal column. And that's very scary because that can cause that patient to be, what's the word I'm looking for when you can't move? Paralyzed. That could cause the patient to end up having a septic infection if that area becomes open. They're going to have spinal surgery. They cannot live with that. So before that patient has surgery, while we're waiting for that patient to have surgery, how are you going to position that patient with spinal bifida? You have to position them prone on their stomach. Why? Spinal bifida is on their back. It's on the spinal cord, spinal column, I should say. And we don't want to do anything to mess with that site to make that sac rupture. That sac rupturing, guys, is a medical emergency. We don't want that to happen, okay? So patients with spina bifida, they're going to be placed prone until we can get them into surgery. Now let's talk about Buck's traction. Why would a patient have Buck's traction? Let's talk about this for a second. Hold on, guys, put my leg up. Let me make sure I'm still recording because this was supposed to be an hour. 1 second, guys. Okay, good, I'm still recording. Okay, as students, you guys tend to get this confused. So let me make sure I explain this to you. You have skin traction and you have skeletal traction. Now, skin traction, guys, the reason a patient will be in skin traction is because we want to keep, we want to keep those muscles from spazzing. We want to prevent muscle spasms. And number two, we want to keep the bones aligned. If that patient had a fracture and the surgeon is on vacation playing golf and he can't come back till Thursday, and today's Monday. Well, until Thursday, we got to keep that patient from having muscle spasms. We got to keep that bone aligned. So what do? We put them in skin traction. Skin traction is non-invasive. It doesn't go into the bone. It doesn't cut into the skin, okay? It just pulls against the skin to keep those muscles from spazzing and to keep the bones aligned. So Buck's traction is a type of skin traction and counter traction is used. Now, skeletal traction, guys, that is the one where the patient goes into surgery and they actually have pins inserted. That is the one where we're worried about that patient getting infection going in through the rods. So we make sure we do skin care and we make sure we clean those rods to make sure that patient doesn't get an infection, okay? That's skeletal traction. Now let's jump to hip replacements. After a patient has had a hip replacement, there are some universal things you guys absolutely have to know. If a patient has had a hip replacement, it's going to take weeks. And when I say weeks, I mean like 6 weeks, right? Before they really start healing. So guess what? They cannot have that hip flexed any more than about 60 degrees, 40 to 60 degrees, no more than that, which means you see how I'm sitting up in the chair, I'm sitting at a 90-degree angle. The patient can't do that, which means they can't drive. They can't sit up in the chair at a 90-degree angle because if they have that hip flex more than 60 degrees, guess what? That bone's going to pop out. So no flexion of the hip more than 40 to 60. Some books say 50 to 60, some say 40 to 60, but I'll tell you this, NCLEX is going to be very clear. They're going to give you a big number. It's either you know it or you don't. They're going to give you something like 75 or 90, or they'll give you a situation where the patient's sitting on a toilet, not an elevated toilet seat, which is what the patient's supposed to have, right? But just sitting on the toilet. How are you going to sit on the toilet? If you're sitting on the toilet, that means you're 90 degrees. That patient who just had a hip replacement, can they sit on the toilet? No. No. That's why they have to have what? The elevation, okay? The head of the bed cannot be higher than 45 degrees. Why? If that head of the bed is elevated more than 45 degrees, guess what? The hips are definitely being flexed more than that 45 to 60 degrees that I told you it should not be flexed. What else is important to know about that patient who's just had a hip replaced? We have to keep them in with a B, abduction. which means if these are the patient's legs, the legs have to be separated. This is abduction and this is adduction. We don't want adduction, ADD, adduction, we don't want that. Why? Because when we have adduction and those legs are together, guess what we're doing to that hip socket? We're making that bone pop out. We want ab with a B, abduction, okay? And so usually we're gonna put an abductor pillow, or we're going to teach a patient if they're going home to make sure they have a pillow or even two between their legs to keep their legs abducted. Very important. If you add ADD, you add those legs together, you are going to cause internal rotation, and that bone is going to pop out of the socket, and we do not want that to happen. All right, I'm gonna switch gears. I'm gonna talk about prolapse cord. We're jumping into maternity real quick. Put yourself on mute, please. Okay, so cord, we're cord compression. Let's talk about prolapse cord. We can see that cord hanging out, and it's not supposed to. What are we gonna do? You only have two choices. You can put mom in knee chest position, or put her upside down. That's called what? That's called what? Trendelenburg position. And the reason we're doing that is to take pressure off the cord. Remember, guys, that cord is the fetus's lifeline. That's how the fetus.
You said Trendelenburg and what else?
Trendelenburg, that's when you put them upside down.
Yeah, yeah, you said that.
Position. Knee
chest.
Knee chest. Yes.
Okay.
Yes. That cord is what delivers the oxygen, the vitamins, the nutrients to the fetus. So that lifeline, we have to make sure that there's no compression. Otherwise, we're putting the fetus in danger. When it comes to maternity, mom's having difficulty breathing. We're seeing fetal distress. What are we gonna do? One of the first things you're gonna do is place mom on the left side. Immediately, when you place her on the left side, guys, it increases perfusion, not only to mom, but to the fetus. It brings oxygenated blood to both, okay? And we're gonna put it to the left side. It's gonna help with the breathing immediately. Some other important things to know, I'm skipping this. Ooh, dumping syndrome. Let's talk about dumping syndrome. If you get a question about dumping syndrome, this is a situation that they normally give you on NCLEX, and that's how you're supposed to recognize that they're talking about dumping syndrome and not anything else. So they'll give you a situation where they tell your patient just had a gastric bypass, or they just had surgery where a portion of the stomach was removed. And this is their first feeding after surgery. What are you going to monitor them for? What are you going to teach them? And you need to know, one of the biggest concerns that you need to be concerned about is dumping syndrome, where it's so crazy because usually we tell patients after you eat, always sit up, never lie down immediately after you eat, right? Well, guys, this is an exception to the rule. If the patient has had gastric bypass, they've had a large portion of their stomach removed, we don't want food going from that stomach to the small intestine too quickly, okay? So we teach them after they eat to do what? To lie down. That is a big teaching to prevent that dumping syndrome from happening. How long are we going to tell them to lie down? For a good 30 minutes. After you eat, lie down for 30 minutes. And another teaching is you teach them when they're eating, they can't eat and drink. Eat and drink. No. They have to drink between meals, not with meals. You see how that one word makes a big difference? Between, not with. Drinks, between meals, not with meals. They are not allowed to drink with meals, okay? Let's talk about amputation. And a reason amputation's big on NCLEX, just about every state is big on NCLEX. I'm going to tell you why. Diabetes is big in every state. So for NCLEX, they're going to kill you with diabetes, no matter what state you're testing for. They're going to kill you with cholesterol. They're going to kill you with hyper and hypothyroidism. They're going to kill you with hypertension. There are certain disorders that I just mentioned. It doesn't matter what state you're testing from. Here in the United States, they're very prevalent. You see it a lot. So they're going to test you on it because those are the type of patients you're going to see more of. So the reason you have a high chance of seeing amputation is because lots of patients with diabetes, if it's uncontrolled, they end up having some type of amputation. Even if it's a little toe, something gets amputated eventually. So let's talk about amputation, guys. If a patient has an amputation above the knee or below the knee, doesn't matter. Well, let's talk about, let me separate it. Let's talk about above the knee. Patient has an above the knee amputation. The first 24 hours, you're gonna elevate that extremity. And the reason you're gonna elevate that extremity, guys, they just had surgery. We're gonna be concerned about swelling and edema. That is going to be a big concern. So that first 24 hours, we're gonna elevate it. But after that first 24 hours, several times a day, when I say several, I'm talking about a solid 4 to 6 times a day, you're gonna have that patient lie prone for a good 30 minutes. Why? Hold on, let me see how I look to you guys, because I'm gonna do a demonstration, but I wanna make sure you guys can see me. Go back to camera. Can you guys see me?
Yes.
Yes.
Oh, okay.
Yeah.
Yes.
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 Can't see myself. Okay, so. All right, patient's got an amputation. Patient's got an amputation, their legs like this. You can see me, right?
Yes.
Okay,
Yes.
so for 24 hours, we have it elevated because we want to decrease the swelling. But after that, you want to know what's going to happen? They're going to have contracture of the hip because it stayed like that. So after the first 24 hours, to make sure that that hip does not become contracted and stays like that, we have to physically force them to go prone, to force this stop to go back like this. Does that make sense? So for good 6 times a day, 4 to 6 times a day for 30 minutes, they have to lie on their stomach to force that stump that was up like this, to force it to come down. That is very important, okay? First 24 hours, elevation, but after the first 24 hours, 4 to 6 times a day for at least 30 minutes, they have to lie down prone. Let me go back to where it was. All right. Again, something else about the above the knee amputation, you're gonna rewrap that stump 3 times a day with elastic bandages. And here's why. It's above the knee. So we expect for, that patient to be fitted with some type of prosthesis. So we want to make sure that it fits well and there isn't any swelling in that area. So as the swelling starts to decrease, that bandage is going to get loose, isn't it? So that's why we're doing it about 3 times a day where we're rewrapping it. If the patient has a below the knee amputation, we're still going to elevate the first 24 hours. We're still going to keep them prone after that first 24 hours, 30 minutes a day, 4 to 6 times a day. We're still going to make sure they don't have any contractures. But if it's below the knee, we're not doing that rewrap of the bandages 3 times a day because most likely they're not going to be getting a prosthesis, okay? Now, something else that you guys need to keep in mind about these amputations, whether it's above the knee or below the knee, the patient can still have phantom pain. And that is pain that the patient feels in the leg that's no longer there. But guess what? They still feel the pain because it's your brain that tells you where you feel pain, right? If I pinch my left arm, it's my brain that's telling me I felt the pinch and it hurts. So even though that leg is not there, their brain hasn't caught up to it. So the brain's still telling them that they feel the pain and you have to treat that patient accordingly. So if they tell you they have left lower leg pain and you don't see a leg there because it got amputated, guess what? You still have to treat them for that pain. Now, what is something that will help besides obviously medicating the patient, treating them as ordered for the phantom pain? Something else that helps is called mirror therapy. where you have the patient in front of a big mirror and they're looking at the mirror and they're looking at the leg that's no longer there. It helps the brain to catch up and say, whoa, there's no longer an extremity there. I don't feel pain. Okay, so the mirror therapy is very helpful in reducing that phantom pain. Detached retina. A detached retina, guys, that is an ocular medical emergency. The patient can go blind due to a detached retina. So you're going to position that patient head downwards on the unaffected side. So if this is a detached retina, their head is going to be down, but on the unaffected side until they can get into surgery. They have to have surgery for detached retina, or guess what? They're going to lose their vision. That's what it is. Let's go to internal radiation. So you have a patient that has, I'm losing my train of thought. They have a radiation implant. You're caring for that type of patient and it falls out while you're in their room. What do? You don't pick it up with your fingers, guys. You don't pick it up even with gloved hands. You're in the room, there's supposed to be metal tongs. You have to pick it up with that metal tong and you place it in a lead-lined basin or can. You cannot put it in a normal garbage can. You pick it up with the metal tong, put it in the lead-lined basin or lead-lined basket or lead-lined can, however they word it, but it's lead-lined. And then you call the radiation department to come pick it up. You never pick it up, because here's the choices they're going to give you. They're going to tell you, pick it up with your hand, pick it up with a gloved hands or sterile gloves, or pick it up with, what's the other choice you'd like to give? Pick it up with a 4x4, a sterile 4x4 dressing. None of those, guys. It has to be a metal tong you would pick it up with and you put it in a lead-lined container. All right, let's talk about spinal cord injuries. So, and I'm going to start with autonomic dysreflexia, which is also known as hyperreflexia. You'll get a situation about a patient who has a known spinal cord injury. They just had the spinal cord injury, and they're going to give you these signs and symptoms. And when they give you these signs and symptoms, they're expecting you to recognize this as autonomic dysreflexia, which is a medical emergency, by the way, guys, because the patient's blood pressure can go so high, they can stroke out, okay? Or they can start having seizures. Here's the signs and symptoms. Pounding headache. Diaphoresis. I'm talking about they're sweating all over the place. All of a sudden, they have a stuffy nose. They have nasal congestion. All of a sudden, you're seeing goosebumps. They have goosebumps on their skin. You're going to see the heart rate go down, which is bradycardia, but you're going to see the blood pressure go up, which is hypertension. Now, those signs and symptoms, along with the fact that this patient has a spinal cord injury, you should be thinking autonomic dysreflexia, okay? And the first thing that you're going to do is put that patient in high Fowler's position. You're going to elevate that head of the bed. You're going to do that first. Then you're going to check for kinks. Because what can cause this, guys? One of the tubing might be kinked and it'll increase the pressure, and that might cause the patient to have autonomic dysreflexia. But that's the second thing. Checking for kinks is the second thing. The first thing you're going to do is reposition the patient. Put them high Fowler's position. You're going to elevate that head of the bed as much as you can. Then after that, you start looking for kinks and tubing. And something else that can cause autonomic dysreflexia, so you have to be very careful, guys. When that patient has a spinal cord injury and they're in the hospital, you need to make sure, because their skin is going to be very sensitive. Did you know that even the wrinkles on the sheet can be enough to trigger that patient to have autonomic dysreflexia? You need to make sure those sheets are pulled taut. You need to make sure that you didn't leave anything in that patient's bed, because something as simple as a pencil in the bed touching their skin will be enough to trigger them to have autonomic dysreflexia. Okay, so in that order, you're going to elevate the head of the bed. check the tubing for kinks. And lastly, check the bed. Make sure there's nothing on there that could have triggered it. Speaking of spinal cord injuries, let's say you get a situation about a car accident and it was MVA. You suspect a spinal cord injury may be involved. You don't move that patient. You do not want to move that spinal column at all. So you're going to make sure that you get what? A spine board, because you don't want to be the one to cause that patient to be, what's that word I was looking for again when you can't move?
Paralyzed.
Thank you. You don't want to cause that patient to be paralyzed. So you're going to make sure you have a spine board, and you got to make sure you keep the head in a neutral position, guys. You can't allow that patient to go like this or like that or like this or like that or like this or like that. That will be enough to cause them to be paralyzed, especially that cervical spine. Okay. So you're going to make sure you have a spinal board, keep the head in neutral position, and whenever you're caring for a patient with any type of spinal cord injury, you're going to make sure that you log roll the patient, right? You can't allow that patient to have any twisting motions. You have to log roll them. Can you log roll a patient by yourself? No. You have to have at least one other nurse with you log rolling that patient. Why? Because you have to move that patient as one unit. You can't have the upper body going this way and the lower body going that way. You just paralyzed your patient. So in order to, sorry guys, give me 1 second. In order to keep that body as one unit, you have to be able to log roll them, which means you have to have somebody else helping you. You can't do it by yourself. All right, let's talk about peritoneal dialysis. So patients at home getting peritoneal dialysis, and as a nurse, you notice what's going in the patient is not coming out. And you're like, uh-oh, what's the first thing you do? The first thing you're going to do, guys, is turn that patient from side to side. The simple act of turning that patient from side to side, the simple act of turning them from side to side should be enough to get that outflow going. Now, if you turn them from side to side and it doesn't work, that's when you do your second thing, which is checking for tubing, checking for kinks in the tubing, I should say. But the kinks come second. You're going to turn them from side to side first. Secondly, you're going to check for kinks in the tubing. All right, let's talk about NG tubes. So nasogastric tubes, guys, we give them a lot to patients who are NPO for an extended amount of time. So if they're NPO for more than a day, we want to what? Decompress the stomach. So we're going to put an NG tube in. But patients also get NG tube feedings. That's very possible. So if a patient's getting an NG tube feeding, you have to have that head of bed elevated at least to 30 degrees. Why? We don't want that patient to aspirate. So that's very important. You cannot have a patient that is on NG tube feedings and their head is flat. Their head needs to be elevated. And you need to be checking for residual, and you have to be getting at least 30 mLs. Let's talk about cardiac cath. Usually, guys, when a patient gets a cardiac cath, the site is usually the femoral artery. So something very important is to make sure that that patient keeps their legs straight. We don't want it bent. We don't want it dislodged. So usually when they ask you about the cardiac cath, it's one of two things they ask you about. Number one, to see if you understand that that extremity needs to be straight. They cannot flex it. They can't bend it. And number two, do you understand that with this invasive procedure, patients at risk for infection? So we are watching those WBCs very closely. We are doing, what's the word I'm looking for? Sterile dressing changes, right? We want to make sure we don't introduce any bacteria into that patient's body. Okay, I'm moving on to post-thyroidectomy. So you guys know the thyroid sits right here on your throat, right? You have your thyroid gland, and those 4 nodules sitting on the thyroid gland is your parathyroid. Great. let's say the patient has hyperthyroidism. The doctor decided, okay, you need surgery. Patient agreed, patient has surgery. They either have a portion of their thyroid removed or the whole thing removed, right? But at the end of the day, they had thyroidectomy. There are some things you absolutely need to know about the thyroidectomy. Number one, you better have an airway kit at the bedside. Think about it, guys. That thyroid is sitting right there on your throat. What happens after surgery or trauma? Inflammation, swelling. Imagine if the patient has inflammation and swelling in their throat. Airway is going to be occluded. So you have to make sure that you have an airway kit right there at the bedside. You have that trach right there at the bedside in case they have airway occlusion, that you can, trach them right there. That's number one. Number two, they remember that thyroid was right here in the neck. So you need to make sure that you keep that patient's head and neck in a neutral position. This is their airway that we're talking about, that they just had surgery, and we're already worried about swelling. We're already worried about obstruction. So you can't have that patient flexing or extending or like this, right? We need their head in a neutral position to allow air to get through there. You're going to be watching out for signs and symptoms of hypocalcemia. Well, why, Professor D? The thyroid has to do with metabolism. When we're thinking about calcium, that's the parathyroids. What are you talking about, Professor D? Well, remember, your parathyroids, those 4 glands sit right there on your thyroid gland. So imagine when the doctor was going in to get rid of the thyroid gland, they nicked one of those parathyroids, because remember, it's the parathyroid that's responsible for calcium. That's all it takes. Now, boom, patient's got hypocalcemia. Patient can go into seizures, because remember, hypocalcemia causes what? Muscle and nerve irritation. So you need to be watching out for that. What are we looking at? We're going to be looking at calcium levels. We're going to be watching out for tetany, right? Remember tetany? We're going to be looking out for Chostek sign, where remember when you touch the side of their face and they go like this, right? That C in Chostek stands for cheek. You touch their cheek and you start to see that muscle and nerve irritation. That lets you know hypocalcemia. We're calling that doctor right away. Or you see the patient doing like this, which is tetany. Or another form of tetany, which is Trousseau's. You take the patient's blood pressure and you see their hand start to spasm. Those are signs and symptoms of I cannot speak. Let me slow down. Hypocalcemia, that we're going to call the doctor right away. Sorry, guys, I keep checking my phone. Today's my goddaughter's birthday, and I have to head down to her birthday party, but I started with you guys late, and I don't want to shortchange you. Okay. Next, we're moving on to nosebleed. Now, a long time ago, we used to teach if a patient has a nosebleed, you put your head back, right? But we learned that that's not best practice, because what the patient ends up doing is aspirating their own blood. So we don't teach that anymore. You teach them to what? Lean forward. We want that blood coming out of their nose, not going back. We don't want that blood entering their stomach. We don't want that blood, we don't want the patient aspirating on the blood. So we tell the patient to sit upright, but lean their head forward. That is the position, okay? Excuse me, guys. Okay, let's talk about mastectomy. How are you going to position the patient after mastectomy? Very important. So patient had cancer, had to be removed. They got rid of either the whole breast or a portion of it, right? But we're still concerned about what? Swelling, edema. You're going to put that patient on the unaffected side. So if they got the mastectomy on the left side, you're going to position that patient on the right side. Now you're still going to have the head of the bed up, because you want the gravity to help with the drainage, but you're not going to place the patient on the side that they had the surgery. We don't want to mess with that surgical incision at all. So you're going to place them on the unaffected side. Now, hold on a second. Let me see those. Now, on the side that they actually had the surgical incision, guys, you're going to elevate it. Why? We don't, oh, guys, I have a shave. Sorry, guys. We don't want to, we want gravity to help with the drainage. So we're going to make sure that they elevate the arm on the affected side. It's going to help drain all of the fluid, and it's going to decrease the swelling. Let's talk about liver biopsy. So remember, guys, your liver, which is important. Remember, your liver, that's what metabolizes meds for you, right? Great, but isn't that also where our clotting factors are made? So the liver is a very, very bloody organ. So it's very important to know after the patient has had a liver biopsy, you're going to place them on the actual side where the liver is, which is going to be on the right side. Why? We want to put pressure on that area. The liver is very, very bloody. That's where your clotting factors are made, guys. So after liver biopsy, you're going to put them on the right side. But before a patient has a liver biopsy, you better be looking at those clotting factors. You better be looking at the PT time, and anything that's abnormal, you're going to report to the doctor. They're going to need to know right away. Okay, and that brings us to diabetes. Diabetes, matter of fact, let me look right now. I'll tell you right now. Hold on a second. That's 1, 2, 3, 4, 5, 6, 7. But diabetes is 9 pages. What I just did with you guys right now, it sounds like a lot, but I just did 3 pages with you. Diabetes is 9 pages. Diabetes is very heavy. So my next, are you guys still with me?
Yes.
Yes.
Okay.
Yes.
We're not going anywhere. We're not going anywhere.
This is good stuff. We're not leaving.
Yes.
Get stuck with practice, Professor D.
You guys are crazy. My my next teaching session is going to be diabetes, and it's probably going to be 2 or 3 teaching sessions because diabetes is very heavy. So I'm going to stop here. Let me, because I did promise to answer some questions. I can't answer too many because I'm running late. Give me 1 second, guys.
Professor D,
Yes.
before you start answering questions, can I just say that thank you so much for taking time out on a Sunday to assist us. And I know that you're not here to ask for love donations, but I would like to have your Cash App to show my appreciation.
Oh my gosh, that's so
for you
kind
for
of you.
today. You know how you just heard your phone chime in while you were teaching? I would like, I hope everybody, or I know everybody pockets are lined up differently, but I hope just not me show, as I hope I'm not the only one that can show you any love.
Yes.
Oh, you're
So
so
can you
kind.
can you give us your Cash App?
Yes.
I've always cash at people. I've never had anyone cash at me. I don't even know what it is.
And can you repeat it 3 times?
Let's do it. Let's
And
do
can you
it.
repeat it 3 times? 3 times.
I'll have to find it. I've never
Interruptions.
had
Let's
anyone
go.
cash at me. I couldn't even tell you what it is.
Go get your husband. Go get your husband.
I might have to. Yeah,
If you
I
just
don't
go on
even.
your Cash App, you would see your information. I think. Now I'm not savvy at all.
I know whenever.
Hold on, I'm gonna tell you right now.
Is it the one with the dollar sign?
Yes, yes, that's it.
That's so sweet of you. Oh my gosh, guys, I'm not asking anyone now, but if you can, that's very sweet. I appreciate it.
Yes.
I want to hear those chimes. I want to hear those chimes.
All right, I'm gonna give it to you guys.
Okay.
I have to tickle pink when I tell them this.
And like I said, repeat it 3 times for the ones in the back.
So it's $.
Okay.
My first name, Eva, EVA.
EVA.
My last
Can
name.
you drop it on the chat, please?
Oh, that's.
Oh yeah, put it in.
Yes, yes.
So we can have it. Yep. Thank you.
That's so sweet, guys.
Yeah, but you are helping us so much. We can't even, there's no word to say, Dr. D. The way you break these things down.
Not doctor yet. I can't take that. I can't take that credit.
No, you break it down.
God willing, but
You break it down to our understanding. I mean, they have so many people doing NCLEX reviews, but yours is like, we just get it, you know? It's
the
really,
voice for me. It's the
yes.
voice.
I get that a lot. If I had a penny for every student that swore up and down that they heard my voice while they were testing, I used to say, I used to tell my husband, I'm like, they're crazy, but I hear it so much. You're like, they hear my voice during testing, but
I hope I hear you when I go in a few weeks.
let me tell you
Me
something.
too.
I pray for you guys. I don't know you personally, but I always pray for you. Anyone that watches my videos, I pray that God helps you pass your test if you're in the program right now or if you're studying for your boards. Just put in the work. You guys are gonna, oh wow. I'm here to think things go off. You guys are going to do great.
Hold on, mine's
Thank you.
Still typing. Hold on.
Professor T.
No problem. So I want to answer some questions, and I don't want everyone answer this at the same time. So go ahead, put it in the chat box so that everyone's not talking at the same time if you have a question. You're welcome. You guys are so welcome.
You're so awesome. There we go.
Oh my gosh.
Sending it through.
This is awesome, guys. Thank you so much. Thank you. You guys are so sweet.
Wait, I got
anyone have any questions I can answer for you? Do you have an NCLEX review? I don't. I was trying to get one going actually for this summer, but the way the numbers are looking, it's just so crazy. And I'm more, if you see me in live, like when I do those sessions, you're not gonna forget. I feel like, you know, I'm doing over the computer, so impersonal. So I don't have any, I don't have anything planned because I really want to do something live, but the way the numbers are looking, it doesn't look like it's gonna happen. If I have to, I might end up doing one, a Zoom where I'm actually in classroom teaching, but it's just not the same. And you know, if students are paying for something, I want you to get your money's worth. I want anything I do, I want you to walk away feeling like, you know, you're just so happy with what you got and you got something that's quality. So at the moment, I don't, I'm sorry. Shanna, my NCLEX, oops, it's going up. I don't know how to slow down the chats. I can't read as fast. Will you do a session on mental health? Okay, if you'd like to see one on mental health, absolutely. I'm gonna finish. Let me make a note right now. That'll be next. I have to finish the diabetes section and then I'll do one on mental health. That's not a problem. Her pop quizzes are great. Thank you. I'm testing on Tuesday. I know. Good luck. Good luck. You'll do great. A pediatric nurse is sent to a med-surg unit. Which patient several times would she be paired with? A pediatric nurse. Okay, so what's the question? A pediatric nurse is sent to a med unit. No, oh, okay, I see what you're saying. Let me tell you guys something. When you guys get a test question and it tells you, you have a nurse from OR that's being sent to med-surg, or you have a nurse from ICU that's being sent to ortho. This is the rule of thumb. Are you guys ready? If it's a new grad or it's an experienced nurse that's floating from another floor, you're going to treat them as an LPN, which means you're going to give them the most stable patient. You guys hear me? The only exception to the rule, exception to this rule is if you have a patient that matches the background of the nurse that's floating to your floor. So I'm going to give you an example. You are working on the ortho unit. You have a nurse that's floating from OR, right? What patient are you going to pair them up with? Normally, you would give that nurse the most stable patient because they're new to your floor. You know how you give LPNs the most stable patient? You would have given that floating RN the most stable patient. But if you happen to have a patient that's post-op from a fracture, guess what? Isn't that OR nurse's background OR surgery? You can give them to the fracture patient, even if they're not your most stable patient. Does that make sense, guys?
Yeah.
So if it's a new grad or an experienced nurse, I don't care. They're going to try to trick you. They're going to tell you that that nurse has been practicing for 50 years. We don't care. A new grad or an experienced nurse, if they're new to your floor, you are going to give them the most stable patient unless you have a patient that matches the background of that floating nurse, okay? Farm, okay, I will also, farm will be after psych, but you guys are killing me because I didn't even promise, you know, well, I'll try to do once a month. Oh my goodness. Med-surg, mental health, okay. Do you have any advice for struggling with tests? I do. I don't know if who asked that question. Nessa, I'm not sure if you watch, I did a video for new nursing students and mistakes that they make. If you haven't watched it yet, go to my YouTube and go to my Fundamentals of Nursing playlist, and it's entitled Mistakes New Nursing Students Should Avoid, or something like that. And in that video, I explain how you're supposed to study for tests, because that's the big problem. Like, forget getting to the test, preparing for the test, you guys are doing it wrong. You guys don't like reading, and you have to read the chapter. You go to lecture, you take notes, you come back home, you have to practice questions. That means you have to have an NCLEX prep book. You can't wait until you graduate to get one. You have to have one now while you're in the program. And it has to be one that's separated, you know, med-surg respiratory, med-surg integumentary, you know, mental health, blah, blah, blah. It has to be cut up in sections. So after you've read, after you've taken notes, you can go into those questions and practice. And while you're practicing, you have your textbook open. So any rationales that you didn't understand, that you got wrong, you can go back into your textbook and read the rationale and figure out why you got it wrong. You have to. And then after you do that, that's when you jump on YouTube and you watch my videos where I'm practicing questions or anyone else's video. But here's what you guys want to do. You want to go on nurse such and such video, listen to what she got to say, and you're like, okay, I studied. No, you didn't. No, you didn't. And I'm telling you guys, it takes a long time, but once you get in the habit of doing it, like I told you, you're going to see your grade go up by a letter grade. Because every single time that you read and you took notes and you did the NCLEX prep and then you watch my video, all of that is registering. So by the time you get that exam, boom, boom, boom. So that's one. Two, another mistake that you guys make, I don't know why you do this. You guys want to take a million years to answer a question. I hate that. You talk yourselves out of the right answer. You'll see a question, you'll see the choice, you know what the correct answer is, and you sit there and stare at it. And while you're staring at it, you're making up a story in your mind. And by the time you're making up the story in your mind, you're choosing an answer to the story that you made up in your mind and not what the question is asking you. Stop doing it. Stop doing it. Stop being a book writer. You see the question, choose your answer and keep it moving. The only time you go back to a question is if you weren't, let's say your paper, obviously you want to make sure you didn't miss something, or you weren't too sure. And then you read something else that triggered your memory and you go back to it. But don't sit there staring at a question and the answers, guys. That kills you a lot. I usually talk myself out of the right answers. Everyone does. Everyone does. All of the students do. Stop doing that. Okay. Thuyaba, can you explain AAA real quick? Okay, so AAA, what does it stand for? Abdominal aortic aneurysm. So very quickly, because guys, I do have to run. Let me tell you what that is. So you know how you have your aorta right here, your abdominal aorta, which by the way, guys, that's the biggest artery in your whole body. That's the biggest one. So just like, you know, you have different arteries in your body, what do arteries do? They bring oxygen, vitamins, minerals, everything that's in the blood, it brings it to the tissue to perfuse them, right? Right. Well, the abdominal aortic aneurysm, which by the way, the abdominal aorta, which by the way, I told you that's the biggest artery in your body. What happens in AAA is the patient will have a weakness in that artery, an outpouching, and that blood pressure can get so high, boop, it bursts. Now think about what I just told you. That is the biggest artery in your body. So what do you think happens when it bursts? You die. Your risk of dying from that is very high, extremely high. Patient has, that thing ruptures, they have a very low risk of surviving. They have to get to the operating room immediately, okay? So you're doing an assessment on a patient. Patient comes in for a normal physical. You're doing assessment on them. You're listening to bowel sounds. You get to the stomach, you have your stethoscope, and you hear a heartbeat in the stomach. Are you ever supposed to hear a heartbeat in the stomach? No, you better call that doctor. That patient most likely has an aneurysm. Remember, the aneurysm is the weakness of the vessel. But guess what? That vessel being weak lets you know that it can rupture at any moment. And the rupture, that is the dangerous part, where the patient will have, you'll see the blood pressure go extremely down. You'll see the heart rate rise. Patient will have a hard, rigid abdomen. What do you think is causing the hard, rigid abdomen? All of that blood that used to be in the vessel, but now is in that abdominal space. If that patient doesn't get into surgery immediately, they absolutely will die. No questions about it. Guys, I'm so sorry. I absolutely have to run. They are waiting on me. I'm so happy I was able to spend this time with you. And thank you so much, guys, for your kind gesture. That was so sweet of you that you guys didn't have to, but I appreciate it. Thank you so much. Too much pressure on artery wall. Yes, very true.
Thank you, Professor.
You're welcome. I'm going to once a month for you. So study, study, study. Watch my YouTube videos. Anything you don't understand, go back into your textbook and study it, okay?
Thank you, Professor.
All right.
Thank you.
Bye.
Thank you.
Thank you.
Thank you.
You're welcome.